Welcome. In this session and the next, we are going to discuss the supranuclear disorders of eye movement. The fovea, as we know, generates high resolution image to identify an object and its properties like shape, color or contrast, and the remainder of the retina outside the fovea has the function of detecting stationary and moving objects in the remainder of the visual field. The supranuclear system provides the function of orienting the visual axis towards an object detected in the peripheral field, and once the visual axis are oriented towards that object of interest, the supranuclear system holds the visual axis steady towards that stationary or moving object. And the supranuclear system consists of multiple centers which converge upon the ocular motor nuclei, that is the infranuclear system. The supranuclear system consists of centers which are both rostral and caudal to the ocular motor nuclei, that is anatomically superior and inferior to the ocular motor nuclei. Now there are 6 supranuclear systems. The ocular fixation system, which holds the image of a stationary object when there is no movement of the head. The vestibulo-ocular system, which holds the image of a stationary object during brief movements of the head. The optokinetic system, which holds the image of a stationary object during sustained movements of the head. The saccadic system, which rapidly orients the visual axis towards a stationary object. The smooth pursuit system, which holds the visual axis steady on a moving object. And the convergence system, which orients the visual axis of either eye to a near object. And we will be discussing each of these 6 systems in the subsequent slide and in subsequent session. The neural structures involved in the supranuclear control of the eye movements are located in the cerebrum, in the brainstem, and in the cerebellum and the vestibular system. The centers in the cerebrum consists of the frontal eye field and the parieto-occipito-temporal junction, and they initiate both voluntary and involuntary eye movements, as we will be discussing later. And these 2 centers project to the brainstem centers either directly or through the superior colliculus and the basal ganglia. The brainstem centers provide the final common pathway for both voluntary and involuntary eye movements. In the pons, we have the pontine paramedian reticular formation and the 6 cranial nerve nucleus, which provide the function of horizontal gaze generation. And in the midbrain, we have the rostral interstitial nucleus of medial longitudinal fasciculus, the interstitial nucleus of Cajal, and the midbrain reticular formation, which provide the function of vertical gaze, vergence, and ocular rolling. And the vestibular system and cerebellum are involved in the vestibulo-ocular reflex. As we will see later, it is important to classify the speed of movement generated by the supranuclear system as either slow or as fast. And the slow movements are generated by the vestibulo-ocular system, the optokinetic system, the pursuit system, and the vergence system. And fast movements are the voluntary and reflexive saccades, the fast phases of nystagmus, which we will be discussing in a subsequent session, and other movements such as ocular flutter, opsoclonus, and rapid eye movements. So we will be starting with the ocular fixation system. Now normally there are subclinical involuntary eye movements with very small amplitude, and the function of these subclinical involuntary eye movements is to prevent attenuation of response to a visual stimulus, which will otherwise occur if the eyes are absolutely still. And these normal subclinical involuntary eye movements are of 2 types, either microsaccades or slow drift movements, which generate the slow phase of nystagmus, which we will be discussing in the session on nystagmus. The ocular fixation system reorients the visual axis towards the target after the microsaccades, which prevent the attenuation of the image on the fovea, producing microsaccadic refixation movements called square waves. So square waves are normal reflexes generated by the ocular fixation system, and these are to and fro conjugate movements with equal amplitude and speed in either direction with a brief intersaccadic interval. The integrity of the system is tested by the ability of the subject to hold fixation steadily on a stationary object while keeping the head steady. The neural substrate providing the function of the ocular fixation system is not very well defined, but does include areas in the prefrontal cortex, the supplementary eye fields, the parietal eye fields, basal ganglia, and the superior colliculi. And the malfunction of this system leads to abnormal eye movements called saccadic intrusions, which are conjugate saccades which disrupt fixation. Conjugate meaning both eye moving together in the same direction with the same speed. And it is said to be a result of dysfunction of pathways which inhibit the reflex response to objects entering the visual field, which thus results in inhibition of omnipause cells and stimulation of burst cells. We'll come to omnipause cells and burst cells when we discuss saccadic system. And saccadic intrusions have been found to occur with a large number of neurodegenerative diseases such as Parkinson's disease, progressive supranuclear palsy, Huntington disease and multiple sclerosis. And saccadic intrusions have been classified depending on the presence or absence of intersaccadic intervals between the two consecutive saccades. And if there is an intersaccadic interval of approximately 200 milliseconds, there is no oscillopsia. Oscillopsia is a vertigo kind of perception by the subject in which the subject has a sensation of movement of the external visual space. Saccadic intrusions with intersaccadic intervals can be classified as square wave jerks, macro square wave jerks and macrosaccadic oscillations. Square wave jerks and macro square wave jerks starts and ends at primary position. That means the two back-to-back saccades occur on the same side of the primary position, and we can see that there is an intersaccadic interval. However, square wave jerks have low amplitude and low frequency square wave jerks are said to be normal, but if they are of a higher frequency, they are pathologic. And macro square wave jerks have larger amplitudes of 5 to 15 degrees with higher frequencies as shown by this graph, and they are said to be always pathologic. And in macrosaccadic oscillation, the back-to-back saccades overshoot the primary position, and macrosaccadic oscillations have large amplitudes in a crescendo-decrescendo pattern. So they have a phase in which the amplitude increases followed by a phase in which the amplitude decreases and the pattern repeats. And macrosaccadic oscillations are evoked by gaze shifts. Saccadic intrusions without intersaccadic intervals consist of saccadic pulses, ocular flutter and opsoclonus. Saccadic pulses occur singly or in series, and they are like square wave jerks but without intersaccadic intervals. They may occur normally or may be found in conditions such as multiple sclerosis and progressive supranuclear palsy. Ocular flutter and opsoclonus, also called saccadomania, are abnormal eye movements which are important to identify because they may be associated with neoplastic conditions. They are high frequency eye movements overshooting fixation, and they have large amplitudes. Ocular flutter consists of horizontal eye movements in bursts, and opsoclonus consists of multiplanar eye movements which are almost continuous and with a larger amplitude. But both ocular flutter and opsoclonus are conjugate. That means both the eyes move in tandem. As I have mentioned, ocular flutter and opsoclonus may be paraneoplastic in origin, and in children it is usually associated with neuroblastoma, in which case we may find anti-neuronal nuclear antibody 1, also called anti-HU antibody, in the serum and or CSF. In adults, it is usually associated with carcinoma breast and or ovaries, in which case we may find anti-neuronal nuclear antibody 2 or anti-RI antibody in the serum and or CSF. Ocular flutter and opsoclonus may also be associated with small cell carcinoma of lung in adults. So if you find ocular flutter and opsoclonus, a neuroimaging of whole body is indicated. Other etiologies include myoclonic encephalopathy, multiple sclerosis, drug toxicity, hyperosmolar coma, and it may occur normally in infants. Regardless of the cause, immunomodulation reduces flutter and opsoclonus. Coming to the vestibulo-ocular system, a very important system which needs to be understood. The vestibulo-ocular system maintains our visual access towards a stationary stimulus during brief head movements. So the vestibulo-ocular system becomes important when the stimulus is stationary and the head movements are brief. And the vestibulo-ocular system is provided by the vestibular apparatus of the inner ears. And the vestibular apparatus of each ear consists of 3 semicircular canals, the utricle and the saccule. Now each one of these structures has a pair in the other ear. which is almost its mirror image and responds in an opposite manner to a particular head movement. And they generate conjugate eye movements with equal speed and in opposite direction to the head movement, as we will be discussing. The response of the vestibular apparatus of each side are opposite to each other only for horizontal head rotation and head tilt. It is not so for vertical head rotation. The three semicircular canals in each ear, the horizontal, anterior and posterior, are responsible for maintaining steady fixation during head rotation. So when the head rotates in their respective plane, the eyes are rotated in the opposite direction so that a steady fixation on a stationary target is maintained. The horizontal semicircular canal responds to head rotation in the horizontal plane, and they each generate contralateral gaze. So the right horizontal semicircular canal is responsible for generating leftward gaze upon right horizontal head rotation, and the left horizontal semicircular canal is responsible for generating rightward gaze upon left horizontal head rotation. The anterior and the posterior semicircular canals respond to head rotations in the vertical plane and also respond to head tilt. The anterior semicircular canals of both the ears generate up gaze upon downward head rotation, and the posterior semicircular canals of both the ears generate down gaze upon upward head rotation. Whereas the anterior and the posterior semicircular canals of the right ear generate leftward torsion of both eyes upon rightward head tilt, and the anterior and posterior semicircular canals of the left ear generate rightward torsion of both the eyes upon leftward head tilt. Now, as we have mentioned, the vestibulo-ocular system generates steady eye movements to maintain fixation on a stationary target only during brief head movements, but during sustained head movements we get VOR jerk nystagmus, which dissipates within a few seconds. And in VOR jerk nystagmus, the slow phase is in the direction opposite to the head rotation, with the corrective fast phase in the direction of the head rotation. The utricle and the saccule constitute the otoliths, and they respond to linear horizontal and vertical movements of the head respectively, and both acting together respond to static head tilt. So tilting the head to one side results in elevation and intorsion of the ipsilateral eye and depression and extorsion of the contralateral eye, and this occurs to maintain horizontal orientation of the visual space as much as possible, and this phenomena is called counter rolling. So if the head is tilted to the left side, the left eye elevates and intorts, and the right eye depresses and extorts. Here we must remember that in the intorsion and extortion of the two eyes in ocular counter rolling, the anterior and the posterior semicircular canals also play a role. Now coming to the central connections of the vestibulo-ocular system, it is usually described separately for the horizontal movement control, the vertical movement control for the downward gaze, and the vertical movement control for the upward gaze. First, the vestibular nerve arises from the vestibular apparatus of the inner ear and connects to the ipsilateral medial vestibular nucleus. And this medial vestibular nucleus is located in the pontomedullary junction. For the involuntary horizontal movement control, fibers from the medial vestibular nucleus innervate the contralateral sixth cranial nerve nucleus, thus generating contralateral gaze as we have described. And for voluntary horizontal movement, the signal arises from the frontal eye field in the frontal lobe of the cerebrum, and each frontal eye field innervate the contralateral cranial nerve 6 and the pontine paramedian reticular formation, thus generating contralateral gaze also. Central connections for control of vertical and torsional eye movements are much more complex and involve the third cranial nerve and the fourth cranial nerve nuclei. Fibers from the medial vestibular nucleus primarily project to three locations: the contralateral CN3 nuclei for control of up gaze and down gaze, the contralateral CN4 nucleus for down gaze, and the contralateral INC. Now these fibers, which project from the medial vestibular nucleus to CN3, CN4 and INC, are located in the medial longitudinal fasciculus, the same structure which we have discussed in an earlier session, which contain connecting fibers from the 6th cranial nerve nucleus to the contralateral 3rd cranial nerve nucleus for horizontal gaze control. Fibers from the INC project to the contralateral CN3 and CN4 through the posterior commissure, and also project to the ipsilateral RI-MLF, the rostral interstitial nucleus of medial longitudinal fasciculus, which is not shown in the diagrams. Both RI-MLFs are interconnected, and each RI-MLF sends descending axons from excitatory burst neurons to INC unilaterally and to CN3 and CN4 bilaterally. Now there is a difference between the pathways controlling the up gaze and the pathways controlling the down gaze. In the pathway controlling the up gaze, the RI-MLFs are interconnected, and each RI-MLF sends descending connections to the CN3 bilaterally. Whereas in the pathway controlling down gaze, the RI-MLFs are not interconnected, and each RI-MLF sends descending connections to CN3 and CN4 only ipsilaterally. As we have mentioned previously, the cerebellum is intimately involved in fine-tuning the vestibulo-ocular reflex. Now, one important thing which needs to be mentioned about the connections shown in these three diagrams for down gaze, up gaze and horizontal gaze is that the green connections shown are shared by the vestibulo-ocular system with other supranuclear systems also. After discussing the normal physiology of the vestibulo-ocular system, we now come to its dysfunction, and there are two signs of VOR dysfunction: spontaneous VOR nystagmus and abnormal VOR gain. Spontaneous VOR nystagmus occurs with imbalance in the vestibular input from either side and happens even when the head is held steady. So normal VOR nystagmus does not occur when the head is held steady, and it is detected by asking the patient to fixate at a stationary object in the distance while holding the head steady. Lesions of the peripheral vestibular apparatus cause a combined horizontal torsional nystagmus, and lesions of the central vestibular connections have either an isolated torsional or an isolated vertical nystagmus, and this difference is important to remember. In the nystagmus occurring due to a lesion of the peripheral vestibular apparatus, the slow phase which disrupts the fixation occurs towards the side of the affected peripheral vestibular apparatus, and the fast corrective phase occurs in the opposite direction. So if the right vestibular apparatus is affected, the slow phase occurs towards the right side and the fast corrective phase occurs towards the left side. And it follows Alexander's law, which states that the amplitude of the nystagmus increases with gaze towards the direction of the fast phase. So when the patient takes on a gaze in the direction of the fast phase, the amplitude of the nystagmus increases. When the patient takes a fixation, nystagmus from peripheral vestibular disorders disappear, but those from central vestibular disorders do not. So this is the second important differentiating criteria of a peripheral vestibular disorder from a central vestibular disorder, the other being the peripheral vestibular disorder having a combined horizontal torsional nystagmus, and the central vestibular disorder having either an isolated vertical or an isolated torsional nystagmus. And with ophthalmoscopy, the nystagmus of the fovea can be seen to occur in the opposite direction to what appears externally. The second important sign of a dysfunctional vestibulo-ocular system is an abnormal VOR gain. VOR gain is the ratio of the amplitude of the eye movement to the amplitude of the head turn in response to which the eye moves, and it is assessed by asking the patient to hold their gaze at a distant object, followed by the examiner suddenly turning the patient's head briskly approximately 20 degrees, first in one direction and then in the other direction, and this test is known as the head impulse test. Under normal circumstances, since the VOR gain is unity, the corrective movement in the direction opposite to the head turn continuously maintains alignment of the visual axis to the target. Vestibular disorders leads to a lag of this corrective response in the direction opposite to the head movement. As a result, the eye appears to drift off the target in the direction of the head movement, and this is followed by a further corrective saccade in the direction opposite to the head movement to realign the visual axis towards the target. The head impulse test can be performed in both the horizontal and the vertical planes to assess the response of the horizontal semicircular canals to horizontal head movement and the anterior and posterior semicircular canals to vertical head movements. As for example, the right horizontal semicircular canal can be tested by a brisk movement of the head towards the right side. Instead of a target, a Nelen chart can be used to determine the decline in visual acuity during these induced head movements, and this is called dynamic visual acuity testing. In this procedure, the patient is asked to look at the Nelen chart while the head is rotated in either direction, first horizontally and then vertically. During dynamic visual acuity testing, unilateral vestibular dysfunction decreases the visual acuity during horizontal movements more than the decline of visual acuity during vertical movements. On the other hand, bilateral vestibular dysfunction affects visual acuity both during horizontal and vertical head movements equally. This happens because under normal circumstances, when the head is rotated horizontally towards one side, only the ipsilateral horizontal semicircular canal responds, whereas when the head is rotated vertically downwards, anterior semicircular canal of both the sides respond together, and when the head is rotated vertically upwards, the posterior semicircular canals of both the sides respond together. To find out whether a gaze palsy is caused by a supranuclear lesion or a nuclear lesion, we can do either a Dahl's-Head maneuver test or a VOR testing. In the Dahl's-Head maneuver, the subject is asked to fixate at a distant target, and his or her head is rotated by 30 degrees in a direction opposite to the direction of gaze palsy. So if the subject presents with a gaze palsy towards the right side, we do the Dahl's-Head maneuver testing by rotating the head towards the left side. In normal subjects and in those with supranuclear lesions, the eyes can be made to move in the direction of the gaze palsy, but this movement does not occur if the gaze palsy occurs from an infranuclear or from a vestibular lesion, and the Dahl's-Head maneuver can be used to test both vertical and horizontal gaze palsies. The second important test to differentiate a supranuclear cause from an infranuclear cause of a gaze palsy is VOR testing, and this is usually done by the otorhinolaryngologist. In a patient complaining of dizziness, we can do Hintz testing to differentiate a benign peripheral lesion from a more serious central lesion, and Hintz testing is a combination of the head impulse testing, nystagmus and skew deviation. As we have seen, the two signs of a peripheral vestibular lesions are a spontaneous horizontal torsional nystagmus with a fast phase to the opposite side and an increase of amplitude with gaze towards the direction of the fast phase, and an abnormal VOR gain, which can be detected with an head impulse test when the head is rotated in the direction of the peripheral vestibular lesion, whether in the horizontal plane or in the vertical plane. Also, after the onset of a peripheral vestibular lesion, there is a very brief period of an ipsilateral hypotropic skew deviation. But following that, there is CNS adaptation and no skew deviation is detected clinically after that. And if all these three criteria are met, the presence of a spontaneous horizontal torsional nystagmus, presence of an abnormal VOR gain, and absence of a skew deviation, that rules out a central vestibular lesion. Because a central vestibular lesion will have a spontaneous nystagmus, but which is either isolated vertical or isolated torsional in nature, and a central vestibular lesion will have a persistent skew deviation. So dysfunctions of the vestibular-ocular system can be manifested by a spontaneous nystagmus, a skew deviation, or an ocular tilt reaction. As we have seen, the spontaneous nystagmus in a peripheral vestibular disorder is a combined horizontal torsional nystagmus that is suppressed by fixation, and spontaneous nystagmus in disorders of the central vestibular connections can be either an isolated vertical or an isolated torsional nystagmus that cannot be suppressed by fixation. A skew deviation is a vertical misalignment between the two eyes and results from an imbalance of the otolithic inputs from either side. And as we have discussed, the saccule and the utricle of the inner ears comprise the otoliths. And this vertical misalignment in a skew deviation can be either committant or an incomitant. In a peripheral otolithic lesion, we usually find a very short-lasting ipsilateral hypotropia. Skew deviation with lesions of medulla and the lower pons also show ipsilateral hypotropia. However, skew deviations with lesions of midbrain and upper pons have contralateral hypotropia. So a hypotropic skew deviation can result from either a lesion to the ipsilateral vestibular apparatus, in which case it is short lasting, or from lesion in the ipsilateral medulla or pons, or from a lesion in the upper pons and midbrain of the contralateral side. An alternating skew deviation results from lesions in INC, cerebellum and the lower medulla. And we find that when the patient alternates gaze from one direction to the other direction, the vertical misalignment alternates, with the adducting eye becoming hypotropic. And this alternating skew deviation can be either periodic or paroxysmal. The differential diagnosis of skew deviation are the other vertical misalignments of the eye, which include fourth nerve palsy, dissociated vertical deviation, and monoocular elevation deficiency. In contrast to a fourth nerve palsy, a skew deviation has an intorsion of the hypertropic eye, a decrease in hypertropia on lying down, and an ocular tilt reaction towards the hypotropic eye. So here we have a right hypotropia from a lesion in the right otolithic apparatus, and here we have a right hypotropia from a left fourth nerve palsy. In a right hypotropia from a right otolithic lesion, we have intorsion of the hypertropic eye and extorsion of the hypotropic eye, as well as a tilting of the head called an ocular tilt reaction. Whereas from a left fourth nerve palsy, the hypertropic eye is extorted and the hypotropic eye is intorted. In a dissociated vertical deviation, the deviating eye elevates, abducts and extorts upon occlusion or during inattention, and in a monoocular elevation deficiency, the elevation limitation occurs only during an attempted upgaze, and we find orthophoria in the primary position. Another manifestation of a dysfunction of the vestibulo-ocular system is ocular tilt reaction, and it results from an imbalance of otolithic input from either eye to the midbrain. So if there is a peripheral otolithic lesion in the left side, there is a left head tilt. This is said to be due to a response to the false impression that the head is tilted to the right because of the relative overaction of the right otolithic input. In addition, there is extorsion and depression of the left eye and intorsion and elevation of the right eye. These two diagrams are essentially different and represent two completely different scenarios. This is a normal subject who has tilted his head to the left side. As a response to this head tilt, the left eye elevates and intorts and the right eye depresses and extorts to maintain as straight ahead a position of the eyes as possible. In contrast, this diagram represents an individual with a lesion in the left otolithic apparatus. As a result of the lesion in the left otolithic apparatus, the head is tilted to the left. In addition, the left eye depresses and extorts and the right eye elevates and intorts, which is exactly the opposite of this situation. And as a result, there is a skew deviation in addition to the left head tilt. An ocular tilt reaction can be tonic, that is sustained, or phasic, that is paroxysmal, and they are said to originate from lesions in different sites. So a lesion in the pathway from the right peripheral otolithic apparatus results in a right hypotropia, and the right hypotropia can occur either as an isolated skew deviation or as part of an ocular tilt reaction. Cerebellar lesions can also cause an ocular tilt reaction on either the ipsilateral or the contralateral side, and as we have discussed previously, skew deviations and ocular tilt reactions from peripheral lesions in contrast to central lesions are short-lasting because of CNS adaptation. Lateral medullary syndrome or Wallenberg syndrome results from occlusion of the vertebral artery or the posterior inferior cerebellar artery, and lateral medullary syndromes may have vestibulo-ocular symptoms such as ipsilesional ocular tilt, skew deviation and nystagmus, which can be horizontal, torsional or upbeating vertical nystagmus. Another feature of lateral medullary syndrome is ocular lateropulsion, that is a tendency of the eyes to move towards the ipsilesional side, and ocular lateropulsion is characterized by movement of the eyes towards the ipsilesional side on eliminating fixation. Saccades and pursuits to the ipsilegional side are hypermetric, that is, they overshoot the target, and those towards the contralegional side are hypometric, that is, they fall short of the target. And on attempted vertical saccades, the movement of the eyes become elliptical. Next we come to the optokinetic system, and the optokinetic system provides an involuntary response to sustained movement of the head or to the movement of a large area of the visual environment moving across a large area of the retina. So response to sustained movement of the head differentiates it from the vestibulo-ocular system, which provides smooth movements of the eyes in response to only a brief movement of the head, and response to movement of a large part of the visual environment moving across a large area of the retina differentiates it from the smooth pursuit system, which responds to only a small target moving across the retina. The optokinetic response to either a sustained head rotation or movement of a large area of the visual space consists of two phases. There is a slow phase movement, which is like the VOR in that it takes place opposite to the direction of the head rotation, thus holding the image of an object steady on the retina. And this slow phase is followed by a corrective saccade in the direction of the head movement to reorient the eyes in the orbit to fixate at a new object. So during head rotation, the VOR and the optokinetic system act synergistically. The VOR predominates for the initial 30 seconds of sustained head rotation, and then optokinetic response predominates. Now we have to remember that the optokinetic drum, although called so, does not actually assess the optokinetic response, since it subtends only a small angle on the retina. It actually assesses the smooth pursuit towards the direction of movement of the drum and corrective saccades in the opposite direction. In contrast to the optokinetic response, the smooth pursuit is voluntary in nature, and it maintains the image of a small moving object on only a small area, the fovea of the retina. Next we come to the smooth pursuit system. Smooth pursuit is a voluntary response to a moving object, and it enables us to track the object with conjugate movement of both the eyes, and it can occur whether the head is held stationary or is moving. However, when the head is moving, the vestibulo-ocular system automatically comes into action, and the smooth pursuit system, in order to track the moving object, has to overcome and cancel the response of the vestibulo-ocular system, which tends to generate a movement in a direction opposite to the smooth pursuit. Pathway for the smooth pursuit system is complex. A moving image stimulates the magnocellular pathway, which through the lateral geniculate nucleus and the primary visual cortex stimulate the middle temporal area in the parieto-temporal occipital region and the frontal eye field. Now descending pathways from these centers pass through the posterior limb of the internal capsule near the optic radiation and innervates the ipsilateral DLPN, the dorsolateral pontine nucleus. Fibers from the DLPN decussate to the contralateral cerebellum, which then subsequently innervates its ipsilateral medial vestibular nucleus. And as we have seen previously, the fibers from the NVN innervate the contralateral CN6 nucleus. So in the smooth pursuit system pathway, there is a double decussation, one here at the level of the pons and the other here at the level of the medulla. Vertical pursuit pathways are similar but converge on CN3 and CN4 nuclei. And to evaluate the smooth pursuit system, we can use either an O'Kane drum or a method called the VOR cancellation. As we have seen, the O'Kane drum does not test the optokinetic system but tests the smooth pursuit system. And in a patient with an unilateral lesion in the smooth pursuit pathway, there will be saccadic interruptions to the smooth pursuit called saccadic or cogwheel pursuits when the O'Kane drum is moved towards the side of the lesion. In the other technique called the VOR cancellation method, the patient's head and the target are moved first on one side and then on the other side. If the smooth pursuit system is intact, it overrides the response of the vestibulo-ocular system to head movement and results in a smooth pursuit, thus maintaining alignment of the visual axis towards the target. If the smooth pursuit system is abnormal, it cannot override and cancel the VOR, and the normal VOR results in dragging of the eyes in a direction opposite to the movement of the head, as a result of which the visual axis lags behind the moving target, followed by a corrective saccade in the direction of the rotation of the head to realign the visual axis towards the target. If the patient's thumb is being used as a target, the VOR cancellation by the smooth pursuit system is normal even in blind patients. As we have seen in the previous slide, unilateral lesion of smooth pursuit pathways produce abnormal jerky pursuits when the O'Kane drum is rotated towards the ipsilesional side. But when the O'Kane drum is rotated towards the contralesional side, the smooth pursuit is normal, and this is also called O'Kane drum response asymmetry. To disrupt the smooth pursuit pathways, parietal lobe lesions have to be large in size. Thus, they also cause contralateral homonymous hemianopia by affecting the optic radiation. Contralateral homonymous hemianopia is also found in occipital lobe lesions, but they do not result in O'Kane drum asymmetry because the smooth pursuit pathways pass through the parietal lobe and not the occipital lobe. And thus, in a patient with a homonymous hemianopia, an O'Kane drum may help us to locate the lesion. Now, saccadic pursuits, when they occur, are usually found in both the horizontal and the vertical directions. But sometimes midbrain lesions can result in selective abnormality in vertical pursuits. Thank you for listening.